Good evening, everyone. You're welcome to our step-by-step to ECG interpretation. My name is Ogumbolu Samson Pamileri. So we'll be discussing about anatomy of the heart, the conducting system. We'll try to identify ECG waveforms, the P wave, the QRS complex, the T wave. We talk about the segment as well, the TP segment, PR segment, ST segment. Then we'll talk about the intervals, the QRS interval, the QT interval, PR interval, and the likes. Then we'll talk about the ECG graphs as well. Talk about the amplitude, we talk about the duration. Then we'll go in depth into the ECG wave. We take them one after the other by talking about the P wave first, the KRS complex, the T wave, the ST segments, and intervals as well. We'll teach you how to calculate the heart rate as well, and we'll show you common cardiac rhythms and so many other topics like myocardial infarction, how to identify ischemia, and so many other things. So the first I'm going to be talking about is the anatomy of the heart. We all know that the heart is an organ, is a muscular organ. We have smooth muscles, we have the skeletal muscles, smooth muscles, the muscles of your stomach, your intestine, and all. Then we have skeletal muscle, the muscles, your bicep, your tricep, and we have cardiac muscles as well. So it's an holomuscular organ, that's the heart, that pumps blood. It helps you to pump blood, which contain glucose, all the nutrients, amino acids, contains oxygen, the gases. It contains a lot of even the medications that you make use of. So this blood helps you, you know, it helps you to perform your daily activities. Without the supply of blood to your brain dies. So the heart helps you to pump this blood to target organs. So how does it do this? The heart itself is actually a fist shape. The size is very, very little. It has a very small size like your fist. Okay, so it's located at the mediastinum. That's the space, a cavity in between your thorax. So, and in the mediastinum, one third of the heart is towards the right, while two third of the heart is towards the left. The heart has four chambers, four major chambers. You have the right ventricle. Look at the screen here. You have the right ventricle, the left ventricle. So tentatively, what I'm saying is that we have two ventricles, the left and the right. Then we have two auricles, or we call them atrium. You have the right and the left. So those are the four chambers. So each chamber, the ventricles are separated by the interventricular septum, which is what you have here. While the atrium, they are separated by the interatrial septum. Okay. In some disease condition, you can have opening in the ventricles, you can have opening in the atrium septum as well, atrial septum. They call it interatrial septal defect, ISD. So you can have VSD as well. So you can also have a very tiny hole called patent foramen ovale, PFO, in your interatrial septum. Now, those are the defects. The essence of the septum is to prevent blood from the right going to the left or from the left going to right, vice versa. Because each compartment, like the left side, has what we call oxygenated blood, while the right side here has deoxygenated blood. In between the left atrium and left ventricle, we have what we call mitral valve, two major valves, the anterior and the posterior mitral valve. Now, in between the right atrium and the right ventricle right here, you have what we call tricuspid valve, three valves, tricuspid. As I said earlier, you have deoxygenated blood in the right side. Why is that? Because blood returning from the body, blood coming from your leg, from your popliteal vein drains blood back to the heart. Arteries are meant to take blood to tissues. So blood coming from your anterior tibial vein, your popliteal vein, your femoral vein, your iliac vein, and they all, drain into what we call the inferior vena cava. So the inferior vena cava is a great vein that drains the lower limb, both the great saphenous, every other vein that you have around your legs and your abdomen. There's another giant vein called the superior vena cava, helps you to drain blood that is returning from the brain, from your jugular veins, your basilic veins, cephalic vein, your brachial veins, and all these axillary veins, subclavian vein, and all this vein network that drains your head, your neck, and your thorax. All these bloods are meant to return back to the heart. These blood, they are welcome into the right atrium. So all blood returning from the body assemble into the right atrium through the superior vena cava, like what you have here, and your inferior vena cava. They return into the right atrium. Now, the blood returning from tissue definitely are going to be deoxygenated because oxygen has been utilized. You can now say that, okay, they will be rich in carbon dioxide. Definitely, because they need carbon dioxide to go out, because that's the byproduct. That's like what you aspire, and you need oxygen to come in. Now, this blood goes through the right atrium into the right ventricle. It doesn't go to the left atrium. There's an opening, which is the tricuspid valve, that opens, that allows blood to come into the right ventricle. Now, when this blood gets to the right ventricle, it's being expelled into what we call pulmonary artery. It's just like a systematic process. The atrium contracts, pushes blood into the ventricles. So ventricles dilate, like they expand. That's what we call diastole. They relax to accommodate this blood. When this blood comes in, then this tricuspid valve closes, because the function of this valve is to prevent blood from returning back into the atrium. Now, this blood is being expelled into the pulmonary artery. This is the main pulmonary artery, or we call it pulmonary trunk. It bifurcates into the left and the right pulmonary arteries. So you can see one goes to the right lungs, the other goes to the left lungs. Now, arteries are big vessels that carry blood to a tissue, okay, from the heart to a tissue. The smaller parts of that, just like you have a dog and you have a puppy. So there are smaller arteries, they call them arterioles. These arterioles, they form a network over time with veins, which are tiny veins. They call it capillaries. Now, these capillary are the bed of the alveoli sac. Alveoli sac harbors the alveoli, which is the end, the terminal point of the air canal. You have your nose, your nasopharynx, larynx, you have your larynx, you have your pharynx, you have your larynx, then you have your trachea that bifurcates, then you have your bronchis, then you have your terminal bronchis, then you have your alveoli sac, which have the alveoli. Now, beneath the alveoli, you have these beds of capillary that helps in gaseous exchange. Deoxygenated blood is being pumped by the right side. Now, this blood gets to the capillaries and exchange happens. Oxygen comes in due to what we call respiration, generation of internal pressure. Like there will be a negative pressure in your thorax to suck in air. When this air comes in, that is respiratory part. Air comes in, oxygen rich air from the atmosphere comes in into the patient, or maybe a nasal pump or any means you have used to administer oxygen to such a patient that still have respiratory muscles that are active, like inspiratory muscles, like your external intercostal muscles, your diaphragm that needs to distend down. When the diaphragm distends due to innervation of the phrenic nerve, it distends, it makes air to come in. That is a natural process, which is negative pressure. That's a negative pressure respiration. Unlike when you have mechanical ventilation, whereby you need to force air into the patient by pumping air, that's a positive pressure. For some majority of the mechanical ventilators that we have some that can do the negative, but they don't really use that presently now. The one you have in most hospitals is a positive pressure. Now, all these things are explanation of the respiratory activities that can occur, that can make oxygen to be available in the capillaries. Now, carbon dioxide is being, expired out because the partial pressure of carbon dioxide is higher in the blood than the atmosphere, so it moves out. The oxygen pressure is higher in the atmosphere than in the blood. It comes in, and when it comes in, it goes into four major pulmonary veins. Normally, arteries are meant to be carrying oxygenated blood, but pulmonary artery carries deoxygenated blood. Now, this blood is being returned back into the left atrium. So everything I explained from the right ventricle to the lungs back to the left atrium is actually called pulmonary circulation. You can read more about that. Now, the left atrium has received oxygenated blood. Everything that happened in the alveoli and the capillary is regarded to as oxygenation. This has happened, and what happens is that this blood needs to be supplied to demanders like tissues, like your skeletal muscles, your intestine, every organ in your body that is requesting blood. They need this oxygenated blood. The blood needs to move into the ventricle. Notice something. When the blood comes into this left atrium, what happens is that the left atrium opens up, it expands to accommodate this blood. It's called diastole. Now, this blood is being ejected. It now contracts. It collapses like this. It contracts and pushes blood into the ventricle. That's the left ventricle. The mitral valve needs to open for this blood to come in. Immediately it comes in, the mitral valve closes, so blood does not return while the ventricle is contracting. This ventricle now pushes blood now into the aorta. This aorta is regarded to as systemic circulation because it takes blood to the entire system, the brain, your liver, and so many other organs in your body. This aortic arch has three major arteries that comes out of it. Now you have the left subclavian artery, you have the left common carotid artery, then you have the brachiocephalic, which is that bifurcates into two major artery, which is the common carotid artery and subclavian. That's the right subclavian artery, the right common carotid artery. And the carotid artery divides into two. You have the internal carotid artery and the external carotid artery. The external carotid artery is the one that supplies your facial muscles, your neck. It has 8 branches. The internal carotid artery is the one that goes into your brain, that supplies your ophthalmic artery, your anterior cerebral artery, your middle cerebral artery, your posterior communicating artery, your anterior choroidal artery, and so many arteries. So the internal carotid artery goes into your brain. All these things are in textbooks. You can always look at it. But this is a brief summary of all these activities that happen. So this blood that goes to the system is being returned back to the right atrium through the superior and inferior vena cava. That is your systemic circulation. Although the heart has its own networks of arteries that supplies it, which is regarded to as coronary artery. You have the left and the right major coronary artery, and they have their branches as well. These arteries, they supply the muscular parts of the heart. They make it possible for the heart to receive oxygen and glucose as well, because oxygen and glucose are necessary for the muscles to perform their function, healthy function. I've really explained the anatomy of the heart. There's so many other things about the anatomy of the heart that is also very important. You have 3 layers of the heart. You have the endocardium, you have the myocardium, and you have the pericardium. The endocardium is the inner lining of the heart. The myocardium is the muscular part, which is the middle layer. Then you have the pericardium, which is the outermost layer of the heart. The pericardium can get diseased because in between the pericardium, it has the viscera, it has the parietal part, fluid, surfactant, sorry about that, and all these fluids that helps in terms of lubrication. Due to infection called pericarditis, you can have excess fluid in this, in this space, in this lumen, that space, and is called pericardial effusion. Now, there are so many other things that can affect the pericardium. It could also get thickened, so constrictive pericarditis. It could get hard, calcified, and all. So all these things are very, very important when you are treating any cause on cardiology. The receiver must be able to understand and have a good background, so you'll be able to understand some pathologies when we get there. That's the reason why we are doing this explanation. This pericardium also helps to attach the heart. That's why your heart doesn't fall off when you are sleeping, although it tilts a little bit when you're sleeping, it moves a little bit, but it doesn't fall off. While you're standing, it should not fall to your abdomen or something. So they help to hold this and so many other things. And so many other things about the heart that I have not really mentioned, but they are very important, which is also the heart actually contracts as a syncytium, which means that when the atrium are contracting, they are contracting together. That's the left and right atrium. When the ventricle are contracting as well, they are contracting at the same time. There are so many things that can happen to the heart that can make some walls not contract. But we won't be going to too much of pathology of the heart. There are so many people with different kind of heart. Some people have just one ventricle. So many people have some big heart, cardiomegaly. There's so many conditions of the heart. Heart can have systolic problem, can have diastolic problem. So many pathology of that, which can be structural and some can be functional, like cor pulmonale now. That's the right heart failure. You can have changes in the structures that now lead to functional, abnormality. Don't get carried away. These are things that you should have known before you participate in this training. But never say never. You can always get it right. You can always get it right. After this lecture, dust your textbook and check out these things. You will understand. It's very easy to understand. Now, the next thing I'll be talking about the heart conducting system. We have 5 major part of this conducting system that's very important. So we have the SA node, like what you have here. We have the AB node, we have the bundle of its bundle branches. That's the left bundle branch, which is this one, and the right bundle branch. Then we have the Purkinje fibers. This lecture is not fast, please. We have so many things to cover. So now, in terms of the SA node is located lateral to the superior vena cava. As I've said, this is superior vena cava, this is inferior vena cava here. This is the right atrium here. So lateral, it is not just one cell. It's a group of cells, specialized cells. They are just cardiac myocytes as well, but they are specialized, banana-like. They help to generate impulses. The heart has the ability to generate impulses itself. It's called automaticity. It generates impulse itself, but the one that generates it faster is the SA node, because other cells make use of sodium influx to generate impulse, but SA node makes use of calcium influx, so it makes it to generate impulse faster, and it can generate impulse about 60 to 100 times in a minute at rest. And when a patient is exercising, or a patient is having infection or hyperventilating, or whatever the condition that is making the patient to be tachycardic, the SA node can pace a rhythm even above 100, which is a sinus tachycardia. This means that any rhythm that is being paced by sinoatrial node is regarded to a sinus rhythm. Just like this is Samson lecture, I'm Samson. This is lecture O, Samson's lecture. So sinoatrial node, pacing a rhythm, sinus rhythm. There's not any big deal there. It's just what it is. Now, the SA node can also pace rhythm lesser than 60. In athletes, patient that took some medications like beta blockers or some disease condition or vagal, stimulation can also cause heart rate to reduce between, less than 60. There's so many conditions. I'm just giving examples. Now, when the heart rate is less than 60, we call this bradycardia. Now, it could be sinus bradycardia, and it could mean some other things. So the fact that the heart rate is greater than 100 or lesser than 60 or between 60 to 100 doesn't make it sinus. That is the advantage of ECG. ECG helps us to spot out an abnormal rhythm. The AV node. The SA node has a fiber, is a bond of fiber that goes to the left side. We call it Bachmann's fiber. Bachmann's fiber. You can look that up. So when I'm teaching, you'll be writing down. You'll be writing down, so you can always play this video over and over again. Now this is a Bachmann fiber, taking this fiber to the impulses to the left side. Now in between the SA node and the AV node, AV node is located, below the septum, interatrial septum, very close to the tricuspid valve, also close to the right side. This is the right side of the heart. Now it has what we call internodal fibers. There are about 3 of them: the medial, the lateral, and the posterior. Now this the medial, the lateral, and the and the posterior. I get the posterior, but they have advanced names. Some call them working back, some call them, and all that. But it's very, very important for your anatomy to remember that. Now these 3 internodal fibers, they send impulses to the AV node here. The AV node is called AV node because it's in between the atrium and the ventricles. So the AV node is in between the atrium and the ventricle. So it's regarded to as AV node. Now the AV node is a group of cells, so they help to transport this impulse from the AV node into the ventricles. So it's at the junction. So any rhythm that is being paced by the AV node is regarded to as a junctional rhythm. Junctional rhythm. Now this AV node itself, it could be diseased in some conditions whereby there's a delay in conduction. So we call it AV node block, or they call it heart block. It can be first degree, second degree, type 1, type 2, then third degree, and all that. Now when it conducts impulse into the ventricles, it conducts impulse into the bundle of E's, like what you have here. Bundle of E's. Now this bundle of E's has 2 branches, the left bundle branch and the right bundle. The left bundle branch has its own branch. The left the anterior fasciculata, what is fascicularis, and the posterior fascicularis and all that. It has its own branches as well. So these also end up with the Purkinje fiber. Now one amazing thing about the AV node is that when the SA node is weak, the AV node can take over the responsibility of the pacemaker. SA node is a natural pacemaker, but AV node can take up the responsibility to pace rhythm as well. Now when it paces rhythm, as I've said, it's called junctional rhythm. The heart rate it can pace comfortably is between 40 to 60 comfortably, which might not be enough, for patients' demand, for muscles demand, organs demand, and all. Now, when it paces rhythm above 60, it's being regarded to as what we call accelerated junctional rhythm. So these things are not complex. The first thing is you need to first understand the rhythm first, understand the conducting system, so that you'll be able to know what even you are looking for. So when you see it, you don't miss it. I'll be introducing you to the waves. So we have the P wave, which is the first positive deflection that you can have here. You can see this ECG that is being isolated is just one of the circles on ECG reading. So the one that is being used for this explanation is the lead 2. We have 12 leads on ECG. There's some ECG that can do 15 leads, but let's streamline to 12 lead. Now the 12 lead, we have lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Those are the 12. Now the V1 to V6 that I mentioned last, they are called chest lead or precordial leads. They are the ones that you generate by placing electrodes on the chest of the patient, on the chest, at the fourth intercostal space as the right sternal border. You place the V1, At the left sternal body, at the fourth intercostal space, you place the V2. At the mid-clavicular line, you place your V4 at the fifth intercostal space. Then V3, you place it in between V2 and V4. Then anterior axillary line, you place your V5, and mid-axillary line, you place your V6. Now, V5, V6, V4, they are placed at the fifth intercostal space. Those are the chest leads. They are unipolar leads. They are chest leads. Now, the other 6, which is the lead 1, lead 2, lead 3, AVR, AVL, AVF, they are called limb leads. So these limb leads are what you generate from your limbs. So let me use this. Let me use this pen to demonstrate what I was trying to say. So there's something that you were taught in school. Where's the eraser? Sorry. Let me just make the image here. Okay, there's a triangle that you were taught in school. This triangle is called a Etovin's triangle. So let's assume that this is my right hand, this is my left hand, and this is my foot. Now there are 4 electrodes you place on a patient's limbs. Patient has, a human being should have 4 limbs, definitely. So if the patient is amputated and you can see only one hand, you can always place it at the, below the clavicle here. You don't need the patient to have 2 hands to do an ECG. You don't need the patient to have 2 legs. You can always place it at the iliac fossa, right and the left iliac fossa there. So now, when you have the right leg, this is your right hand here. The right leg here is used for earthing on ECG. So in some other class where we'll teach you how to place electrodes, we'll teach you better. The right leg is earthing. It does not contribute to the lead formation, the 6 lead formation. So now this is your right hand here, your left leg, which is a foot, your left hand. A negative charge reacting with a positive charge from your left hand forms what we call lead 1. Lead 1 is one of the leads that you see on your ECG. So you have lead 2 formed from negative charge from the right hand and positive charge from the foot. Then you have a positive charge from the foot and a negative charge from your left hand to form lead 3. So this is what Etovian triangle means. Now, lead 1, lead 2, lead 3 are called bipolar limb leads. They are the only bipolar leads. The reason is because they are formed by 2 poles are coming from the patient itself. You can see one is coming from the right hand, the other is coming from the left hand. One is coming from the right hand, the other is coming from the left leg. So it's 2 poles. 2 poles need to come to form a lead. What is a lead? A lead is formed by reaction of 2 poles. It forms a lead. Now, lead 1 has been formed, lead 2 has been formed, lead 3 has been formed. How do you now form AVR, AVL, and AVF? Just a charge from this right hand, and the machine will augment, will give you the second charge. If a negative is coming from the right hand now, the machine gives a positive. So this lead is regarded to as AVR. The one that reacts with the left hand is regarded as AVL. The one that reacts with the leg is regarded to as AVF. Now, if you notice, there's V in AV, 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 and there's also V in V1, V2. So the trick I use is when I see V, I know they are unipolar. When I don't see V in the leads, I know they are bipolar. So 3 leads are bipolar, then 9 are unipolar, but 6 of the 9 are chest lead or precordial leads. So definitely that is how. So the one we make use of here is lead 2. We use this lead 2 for explanation because lead 2 has a prominent P wave. Lead 2 has a prominent P wave. So we make use of lead 2 for explanation. Even for your reading strip, lead 2 is what we make use of because it has prominent waveforms. Now, let me clean this off. I hope you understand that. Okay. So now, let's now go back to what we are saying. Now, let me just quickly say something before I leave the leads. The ECG lead can also tell you a lateral wall. It can tell you information from the inferior wall, anterior wall. So quickly write this down. Lead 1, AVL, V5, V6, they are regarded to our lateral wall, leads. Lead 2, lead 3, AVF, they are regarded to as inferior wall leads. Lead V1, V2, they are regarded to as anterior wall or septal wall leads. Sorry, V3, V4 are regarded to as anterior wall lead, but some people will still say V1 to V4 is still anterior. Now the AVR, well, they will say it's read from the superior part of the heart. I don't know much about the AVR because whatever the AVR will tell you, other lead will tell you. But researches has been coming up now that the AVR can tell you about old MR, old myocardial infarction, that's MI, and it can tell you some other things. The AVR can also be used to distinguish between lead reversal and in a normal ECG. Like when a patient has a normal ECG now, everything in AVR is meant to be inverted. But when the AVR, the lead in AVR is taller, is upright, like the KRS complex is upright, in that situation, you'll be thinking of, wow, this is probably a lead reversal. Or the patient has what we call dextrocardia. Levocardia is when your heart is more at the left. Dextrocardia means that the heart is now more at the right. So anything you'll be seeing in your ECG will be upside down. So how will you be able to distinguish between levocardia and a lead misplacement when you put a reversal? Where you're supposed to put right hand, you put left hand, and you put left hand where you're supposed to put right hand, and dextrocardia. Everything will be upside down, like opposites in dextrocardia. But in terms of lead reversal, you only have the changes on the limb leads. The chest leads will be normal. So you know that you made a mistake in your ECG lead placement. It's not an issue with dextrocardia. So you can quickly call for a repeat ECG. Oh, so now let's talk about the waveforms now. This is a P wave. You can see this is a P wave, this is a Q wave, the negative. Then this is your R wave, this is your S wave. S wave is starting from here downward. Then you have your T wave as well. This is your T wave, which comes after the KRS complex. Now, this is your PR segment in between your P and your KRS complex. In between your KRS complex and your ST and your T wave, you have your ST segment. In between this T wave, because the next thing you're supposed to see here is a P wave, it continues like that, is the TP segment. Now we have intervals. PR intervals is between from the beginning of the P wave to the beginning of the KRS complex. So if it's Q wave that start the KRS complex, you end there. Or if it's R wave that start the KRS complex, you end there. Now the QT interval is from the Q wave or maybe R wave or any from the KRS complex to the end of the T wave. Those are the major intervals. Then you have the KRS intervals from the beginning of the Q to the S. These are the waveforms. Now, what does P wave indicate? P wave indicates atrial depolarization, not atrial contraction. Atrial contraction occurs in the middle of this P wave to this end of the beginning of the KRS complex, from the middle here to the, so it's not, P wave is not atrial contraction, it's atrial depolarization. Depolarization means you're taking a cell from the polar state to action potential. So like you are introducing sodium into the cell so that its electronegativity can go away and you have what we call electropositivity, so the cell can contract. So the atrium contract after depolarization. Then the KRS complex indicates ventricular depolarization, not contraction. So this is ventricular depolarization and T wave is ventricular repolarization. I know you'll be wondering that where is now ventricular repolarization, atrial repolarization? It's actually embedded in the KRS complex. It's a very minute activity, so you can't see it. You can't see it. The KRS complex is a very bigger muscle, a bigger chamber compared to the atrium. So its depolarization overshadows. You can see how big the depolarization of the ventricle is, and look how small the repolarization is. Repolarization means that you are taking the cell back to resting membrane potential by giving out potassium as the electrolyte. Exchange of electrolyte brings about depolarization and repolarization. So this is now a long rhythm that shows the P wave, the PR segment. You can see this is your KRS complex, this is your ST segment from this to this. You can see your T wave, then you have your P wave. That's why I said in between the P wave and the T wave is what we call TP segment. You can see it here. So the T wave comes after this. So when we get to P wave proper, we'll be able to explain to you, this waveform one after the other. Now, what really happens in the heart during action potential for the heart to actually contract? So look at the screen here. This is what we call action potential curve. You can see this action potential curve. It has 4 different phases. It has 5 different phases, sorry. It has the phase 0. The phase 0 is this long part, which initially starts from diffusion. Let me use the word diffusion of sodium, because sodium is actually plenty outside the cell compared to inside the cell. If you remember your blood and body fluid, whereby you have 40% of fluid inside the cell, 20% of fluid outside the cell. So inside the cell, intracellular; outside the cell, extracellular. Extracellular is further divided into intravascular, interstitial. Interstitial is the one that bats the cell. Remember all this physiology. Then intravascular, you have your red blood cell, your white blood cell, your thrombocyte. Then you have electrolytes. Sodium, even when you do your EUCR, electrolyte, urea, creatinine, you discover that sodium is about like 145, like 135 to about 145 sodium. But when you're talking about potassium, you have 3.5 to 5.0. That's to show you that that compartment that was being measured, which is the blood, sodium is plenty compared to potassium. So potassium is plenty inside the cell. So what happens is that from outside the cell, sodium comes in through the sodium gated. When the electropositivity inside the cell increases, like let's say there's negative here. Okay, follow me please. When there's negative here, this electronegativity. So this is like minus 70 millivolts. Minus 70 millivolts inside the cell, minus. So when sodium begins to come in through diffusion, this begins to change to plus. That is what we call depolarization. You are changing it from that polar state. Now, when this change to plus, definitely from minus 90, let's say minus 90 for cardiac muscles, minus 90 to like plus 15 or plus 30. All these things has to change to plus. So when it's getting to like minus 30, minus 20, then what we call voltage gated channel opens. Then sodium begins to rush into the cell, because now something is now charging it for it to come inside, demanding its necessity. So when it comes inside the cell, it takes the cell to the positive phase, which is like action potential. Potential means that you have the capacity to perform something. Doesn't mean that you will perform it, because you can have a potential for something, but you don't have an interest to do it. You have the potential, but you don't have, every necessary tool to do it. So there are some muscles that are dead. Even when you take them to action potential, they will not still contract. So what really happens inside the cell? So there's something called this is a cell membrane. This is a cell membrane. So let me get. Sorry. So this is a cell membrane. So this is a transverse tubule. So this is your sarcoplasmic reticulum. So when positivity begins to run, within the cell, it begins to go like the charge begins to go. It begins to go like this. It runs down. This is a transverse tubule here. So it comes into this sarcoplasmic reticulum, which have calcium inside. So there's calcium here. So calcium is carrying a 2+, right? So everything I will see explain on this. Now calcium is carrying a 2+. Now this calcium is now being released because of this charge into the cell. So when this calcium is being released, okay, there's something called troponin complex. troponin complex. So it's just like this, 1, 2, close to each other. Then you have one on top. So you have the calcium part, you have the troponin high, troponin T. For some of you that, when a patient have heart attack, that you've seen them send for a cardiac biomarker, you discover that they check the level of this troponin I and troponin T, because when there is heart attack, the cell wall breaks. So all these contents will come into the bloodstream. So you can be able to test, this kind of these elements in the blood. When you now see the markers, you now say, yeah, this patient just had an heart attack or thereabout. So this calcium binds to this troponin part. Now, the troponin is sitting on what we call myosin and actin. It's sitting on the head of the myosin precisely. So the moment it binds to this, what happens is that there's a shift from the head of the myosin. So the myosin can now strike on the actin. When myosin head, they call it power strike. When it strikes on it, that brings about contraction. Do you understand? Now, this calcium needs to return back to this sarcoplasmic reticulum through what we call active transport. So you need an ATPase to do that. In skeletal muscles, because of the necessity of the ATPase, the need of the ATPase, that is not available. When there's contraction, this calcium can accumulate in the cell and lead to what we call tetany, sustained contraction, and it's painful. So, but in cardiac muscle, we don't have tetany because there is a plateau phase. You can see the duration. Now, this is your phase 0, right? Sodium comes in. Here in phase 1, potassium is trying to go out because sodium has gotten to action potential and definitely contraction is about to happen. So potassium is going out. Potassium is plenty inside the cell compared to outside the cell. Potassium is going out. So what now happens is that in phase 2, calcium that came in here now comes in here. So in phase 2, that's why you now have this kind of plateau, a kind of hump like this. So potassium is going and calcium is coming, but calcium is carrying a 2+. So the curve is still going up. That's why it's not flat, it's going up. Then calcium is being returned. These things I explain here. Calcium is being returned, potassium continues to go out. So when potassium is going out, it's regarded to as repolarization. So this phase 1 is early repolarization, but this one is complete repolarization. So when you now get to the baseline, this is supposed to be baseline. Don't mind this. This is hyperpolarization. It has gone above, beyond the baseline. So it's supposed to be around here. So here is now resting membrane potential. So this is your phase 4. Now this, if you divide this into 2, this part is called relative refractory period. Now, this part is called absolute refractory period. For somebody that have premature ventricular complex, or patient that complain, I'm having palpitation in a skip beat or something. At this point, if an impulse is being stimulated on the heart and that cycle can begin immediately. So you have a premature cycle. But the moment the phase has gotten beyond this other line, the moment the phase has gotten beyond this line, there's no more contraction that can happen except the next cycle begin. So this is an absolute refractory period. Now, how does this relate to your ECG? You can see your KRS complex here. That is ventricular depolarization. This is your depolarization phase. So this T wave here reflects the phase 3 and phase 4. That's your repolarization phase. Now, ST segment here refer to your calcium level. So if your ST segment is short, for example, you can check for hypercalcemia. You can do a test for hypercalcemia. Calcium level. So if your ST segment is wide, you can do a test for hypocalcemia. Now your T wave, if it's tall and tainted like this, you'll be thinking of hyperkalemia. Kalemia, that is potassium level. Now when it is inverted or flat, you'll be thinking of hypokalemia. So all these things can help you in electrolyte level, but it's not a diagnostic tool for electrolyte because most times even severe hypokalemia, you can have U wave. But in some patients, they might have a U wave without. U wave is another waveform after. Normally, it's supposed to be T wave, then P wave, but you might have a U wave before another P wave. It's now look like you're having two P wave, but it's only small most times. But you can see it on patients and it doesn't mean anything. But in some patients, it can mean severe hypokalemia. All right. Sorry. So you can always play back this lecture. You can always play it in a slow motion, or always, anything you want to do, you can do. Let's go to the next slide. So let's quickly talk about the ECG graph. Now we have the small boxes and we have the big boxes. So in the next class, we'll be talking about the ECG graph. We'll be taking it gradually. Let's stop here so that many people can watch this, and in the next class we proceed from there. Thank you so much, everyone.